Shall we go live? Are we live?
Yes. Yes.
Are we good to go?
Yes. Yes, we
Yeah.
can go ahead.
Okay. Good evening, everyone. Welcome to this Facebook Live session on Unexplained Infertility. I'm Dr. Parinaaz Parhar. I'm the Clinical Head and Fertility Specialist at Oasis Fertility Secunderabad. Today, I'll be talking about unexplained infertility. Is it reversible? Do we have any solutions for this highly frustrating diagnosis? So, what exactly is unexplained infertility? Like you can make out from the terminology, there's really no explanation for the reason, for the cause of the infertility in these patients. So how do we come to a conclusion that we have really not been able to find anything? It's defined as a condition where there is a failure to establish pregnancy after 1 year of unprotected vaginal intercourse. So basically, infertility is defined as when you have been trying for more than 1 year and you have been unable to conceive in spite of having regular unprotected intercourse. But to reach a diagnosis of unexplained infertility, we have been unable to uncover any reason for your infertility despite doing all regular tests like a semen analysis, checking for your ovulation, and trying to establish your tubal patency. The routine tests which we use in order to find out the cause for the infertility in a couple are unable to find anything wrong with the couple as such. The semen analysis seems to be normal. The patient seems to be ovulating. The other thing is that the female partner's tubes also seem to be patent. There seems to be absolutely nothing wrong. But in spite of that, the couple seems to be having difficulty in conceiving. Or even if there were some issues, after correction of the factors with the variable treatment options available, we are still not able to help them conceive. Like we see in patients who are having irregular cycles, if a patient comes to me with PCOS and I have been giving her treatment, this lady has irregular cycles and I have been giving her tablets in order to make her eggs ovulate every month. And in spite of me seeing that she is ovulating, we've still not been able to help her conceive. So she is ovulating, her tubes are patent, and her husband's semen analysis is normal. But yet, the couple is finding it difficult to conceive in spite of everything being normal for about a year, more than a year of trying. Now, to understand this better, let me just try and explain to you how normal pregnancy happens with the help of this diagram. So this is the female genital tract, and as you can see it, this is what a normal uterus is supposed to look like. These are the tubes. You're supposed to have two of them, one on each side, and these are the ovaries. Well, this is the vagina. So in a lady, every month she has a couple of follicles which are growing, out of which one of them becomes bigger than the others, and that grows and ovulates. That is, it comes out of the ovary at around a fixed time in the cycle in a patient who's having regular periods. Once this egg comes out, it is alive for about 12 to 24 hours. So, if the couple has intercourse in that window of time, then the sperms which are deposited in the vagina will travel up the uterus through the tubes. The egg which is released from the ovary will be picked up by the tubes. The sperm and the egg meet in the tube, and the embryo which is formed here then it travels all the way up to the uterus, and in the uterus it implants, and this is where it grows and establishes a pregnancy. So as we can make out, for normal pregnancy, the husband's semen parameters should be normal. What do we normally test for? We look at the count, we look at the motility of the sperms, we look at the shape of the sperms. If these parameters are normal, we assume that everything is normal with the male partner. As far as the female is concerned, we usually presume that she's having regular cycles. That means we usually presume that she's having proper ovulation, that is, the egg is getting released every month if she gets a history of having regular cycles. This can also be confirmed by means of an ultrasound scan. To know whether the patient's tubes are functioning or not, it's very difficult, but we can try and analyze whether the tubes are open or not with the help of two basic tests. One is known as a hysterosalpingography, which is where, with the help of a dye, we check whether both the sides the tubes are open or not. The other test, which is more confirmatory, is by means of a laparoscopy. So these are the tests which we use in order to find whether the patient is having open tubes or not. The third thing which we tend to analyze is whether the shape of the uterine cavity is normal or not, and that is usually done with the help of an ultrasound scan. So if a patient has normal semen parameters, if the wife seems to be ovulating regularly, if the tests which are being conducted to determine the patency of the tubes are showing that the tubes are patent, and the ultrasound is saying that the uterus seems to be fine in shape, in spite of all these test results being normal, if still the couple is having difficulty in conceiving, it is known as unexplained infertility. Now, what is the incidence of this particular condition? Well, there has been data which has suggested that the incidence of unexplained infertility out of all patients suffering from infertility may vary anywhere between about 15 to 30%. That is almost about one third of the couples who are suffering from infertility. We might find it actually very difficult to find out pinpoint a particular reason as to why they are infertile. This can be a very frustrating diagnosis because the obvious question which is going to come to the patient's mind is that if the doctor doesn't know what they're treating, how are they possibly going to treat? So it's a very frustrating and diagnosis which leads to high levels of anxiety. But that doesn't mean that we don't have any treatment for this. So if a couple has a diagnosis of unexplained infertility, what are the options before us? Obviously, first we have to try and counsel the patient. Now, the counseling mainly revolves around the fact that because you have unexplained infertility, because we have not been able to find out any particular reason, doesn't mean that there's nothing that we can do. It doesn't mean that you're sterile. You might just be suffering from subfertility. So, if the treatment of the condition basically is determined by what is the age of the female partner and for how long the couple has been trying. If the wife's age is less than 35 years, and if the couple has been trying for, say, less than about 2 to 3 years only, we can try and do something known as an expectant management if we feel that the wife has an adequate ovarian reserve. There is the importance of ovarian reserve in this particular context because, unlike men, females are born with a fixed number of eggs. So, as our age increases, the number and quality of the eggs decreases. If we have a young patient who is blessed with a good ovarian reserve, we can try something called as an expectant management, where we are very conservative in the management of this patient with unexplained infertility. On the other hand, during routine investigations, if we find that the patient is suffering from either a borderline ovarian reserve or she has low ovarian reserve, we know that the longer we wait to treat this couple, her reserve is going to deplete further, which is going to make it more difficult for her to get pregnant. So in these patients, we tend to be more aggressive in our therapy. So coming back to what do we do if a couple, if we've conducted all the tests and we find that there's nothing wrong with you, what can we do? If you're a young couple and the wife has a good ovarian reserve, it's worth mentioning to you that about 84% of the patients of couples who have been trying usually conceive within 1 year of their trying for a pregnancy. Another 8% would conceive within the next 1 year. That is about 92% of patients who are trying might conceive on their own within about 2 years of starting to try, and 94% within after 3 years, which makes it a strong point to consider that if you give these patients enough time, without really making them anxious about the fact that they are not conceiving within the stipulated time period of 1 year, they might conceive on their own because they're not really infertile, they're subfertile. So you give them some more time to try and they might conceive on their own. The best candidates for this kind of expectant management are those who are young, who have not been married for long, where the duration of infertility is less than 2 to 3 years, and the wife has a good ovarian reserve. So, as far as expectant management is concerned, patience is the key, because after 3 years, almost 60% will conceive spontaneously. But this is not the right option for everyone. And your patient will not just be satisfied with you telling them, okay, let's just wait and watch. They want to understand that, okay, you were not able to find out the reason for my infertility, but what could it possibly be? It's very important for us to understand that the terminology is unexplained infertility because the routine tests which we are doing are not giving us the precise answer to this problem. That's because the process of reproduction is a very complex thing. There are a number of steps, there are not number of things which are happening at the microscopic level, and it's not practically possible to try and test everything. There are limitations to the tests which we routinely follow, and they might not pick up the subtle problems which might be existent and responsible for your infertility. So as we can see from this diagram, which is very beautifully showing here, the problem can be at various levels. You might be having a problem right at the level of the ovaries and the eggs. There might be a problem at the level of the tubes. There might be a problem at the level of the uterus. When we routinely investigate a patient, we are not testing for everything because it's not called for. But we are aware that these can be the problems that the patient might be suffering from. So to name a few, what are the problems that can be responsible for unexplained infertility? Let's start with the semen parameters. Now, if we look at the semen parameters, like I mentioned in the beginning, when we are checking the male patient's semen parameters, there are only 3 or 4 parameters that we check for. We're looking at the sperm count, we're looking at the sperm motility, and we're looking at the sperm shape. We are assuming that if all these parameters are in the normal range, the male is healthy. Now that's being over optimistic because even if everything is looking normal, it might not be functioning normally. The sperm still might have difficulty in trying to fertilize the eggs. It might look normal, but there might be high DNA fragmentation index. There might be some associated immunological problem. There might be some anti-sperm antibodies. All these things which are not routinely responsible might be responsible for the unexplained infertility, which is basically caused because of the male factor in these cases. So it's important to remember that though we are trying to do the elementary tests, we have not ruled out everything. And these small things can be what is responsible for your infertility. The other thing is if we look at the female parameters which are untested and which might be responsible for the infertility in these patients, there might be some problem with the egg quality. Now, like I was saying, when we use the terminology unexplained infertility, we usually use it for patients where the wife has been tested to be ovulating regularly. How do we see that the wife is ovulating? We see that she's ovulating if she gives a history that she's having regular cycles. And if on scan we're seeing that the egg is coming out of the ovaries, there is some fluid in the pelvis at the time of the scans and the egg has collapsed. However, what we don't test for is there actually an egg growing? What we are using is we're just seeing a follicle which is growing on scan. But what is the quality of that egg? If it came out, was it picked up by the tube? Was the hormonal milieu correct? All these minute things are not checked with the help of routine tests, and these might be what might be wrong. This is what makes the difference between a fertile couple and an infertile couple. When we come to the tubes, there might be adhesions in the pelvis which might make it difficult that even if the egg is coming out of the ovary and even if the tubes have been tested to be open, the tube is not able to pick up these eggs. Okay, even if the tube is open, it's not just about the patency of the tubes, it's even about the functioning of the tubes. The tubes have small hair-like structures called cilia inside them, which basically help in pushing the egg towards the sperm and the sperm towards the egg, and the two together towards the uterus once fertilization happens. So, if this hair is destroyed because of any infection, this function might not happen properly, and this might be responsible for infertility in patients even where the tests are showing that the tubes are open, but they might not be functioning correctly. The other thing is that maybe the sperm is not really able to penetrate the egg. Maybe the egg has a very hard covering. These can lead to absence of fertilization altogether. Even if fertilization is happening, it might result in poor quality embryos. And maybe the embryos are not growing all the way up to the blastocyst stage, because of which, even though ovulation is happening, even though the tubes are open, and the sperm and the egg are meeting, we are not getting good quality embryos, and because of which the pregnancy is not progressing further. In some patients, there's even a problem with the process of implantation, where the embryo comes and deposits in the uterus. So suppose if the patient has poor thin quality endometrium, or there is some basic local structure, or there's a displaced window of implantation, in these patients, it is difficult for implantation to happen. And again, the patient would be categorized as having unexplained infertility. Most of these conditions, most of these things, most of these abnormalities can be overcome by IVF. But we don't routinely suggest IVF to everyone because it is the most expensive treatment. There is a very step by step approach which is given, and we will be discussing that one by one how the different treatment protocols work. So I've already discussed about how expectant management is helpful in some patients who have very good prognosis, who have been married for short duration of time with good reserve, and where the female partner is young. The other option which is there is that while they are planning now, if I'm telling a patient to try naturally for another 2 years, what am I actually telling them to do? Well, in those 2 years, the advice that is usually given to these patients who have good prognostic factors are that try and improve your nutrition, try and do some lifestyle modifications, try and have a healthy diet, cut down on your alcohol consumption, cut down on your caffeine intake, try and include healthy include some form of exercise and meditation in your daily lifestyle. Try and reduce your stress levels because all these factors to an extent might be responsible for causing your subfertility. And these are things which you can do at your personal level to try and improve your chance of improving your fertility. Now, the patients very often ask us that should we really be following the calendar method now to increase our chances of pregnancy? I would try and advocate against it because it is a very stressful thing. If I tell a patient that this is the time of the month when when you have maximum chance of conceiving and mark it on the calendar and just try and have intercourse around that time, I have seen that the stress actually kills their chances. So it's rather that what we would advise the patient is that, you can try and have intercourse maybe alternate day. It's not required daily because once you have intercourse, the sperm is alive for about 3 days in the vagina. So you can either time your intercourse alternate days during the weeks when there is a high chance of conception, or at least about 3 to 4 times a week should do the trick. So I would not say that follow the calendar method strictly and try to figure out with the help of LH kits what is the right time to, when you're having the LH surge and when is the right time to try and conceive. No. Take it easy on yourself. We have given you enough time. Try and follow the doctor's instructions. And this is something which leads to a lot of anxiety and doesn't really help as much. Now, another option which is available, we spoke about expectant management. We spoke about what to do in that expectant management. Now, there are some patients who might benefit from laparoscopy. Now, what is done in laparoscopy is that laparoscopy helps us in assess the pelvic cavity of the patient to try and see that are there any pathologies, is there anything abnormal in the pelvis which might be stopping the patient from conceiving naturally. So laparoscopy should be performed in women with unexplained infertility who have signs and symptoms of endometriosis or in whom we are suspecting some kind of adhesions. Because as we can see from this beautiful diagram here, that mild endometriosis or conditions which lead to the disturbance of the relationship of the tubes with the ovaries might be responsible for the infertility. So laparoscopy offers us the chance of not only diagnosing the problem, it also gives a chance to try and correct it. If a patient has minimal mild endometriosis, which might not be picked up on routine ultrasound scan, we can try and ablate the lesion and improve the patient's chances. The other thing is that if the patient has some kind of adhesions, that means the tubes and ovaries are stuck together because of some prior infection, we might try and release it to improve the chance of patient's conception. Besides that, laparoscopy would help us diagnose the problem and the condition would not be unexplained anymore. If there's too much of adhesion or if the endometriosis is of a severe grade, we can tell these patients that, see, it's very difficult for you to try and conceive naturally, and IVF is the only option here. So it's not only diagnostic, it's also therapeutic in these patients. Now, we can try and correct whatever we can, and for the others, we can at least give them a fair idea about what is the chance of conceiving naturally. What are the pathologies which are most commonly detected on laparoscopy? Well, in a good percentage of patients, endometriosis is picked up of various grades. We might see adhesions, and in some of them, though your HSG might say that the tubes are patent, we might see on laparoscopy that the tubes actually look very unhealthy. And these are the kinds of tubes which might be having difficulty in functioning as well. So what is the, now this was about laparoscopy. The third option which is available for these patients is to try and do something called as an IUI, which is known as an intrauterine insemination. Now, IUI is a very commonly offered treatment modality in patients with infertility. In unexplained infertility, it is usually offered in order to increase the monthly pregnancy rate above the natural rate of about 1.5 to 3%. How does it work? Well, the ovarian stimulation, which is done in patients who are undergoing IUI, helps to improve the gamete quality and quantity, and it helps to facilitate the gamete interaction. What do I mean by it, and what exactly is an IUI? So what I'm doing in an intrauterine insemination is that the time when the egg is coming out of the ovaries, which we usually confirm by means of an ultrasound scan, at that time we ask the male partner to give the semen sample in the laboratory. There we process the sample and we get a centrifuge of good quality, low volume sperms. So we take a small concentrate of sperms, which is high in motility, has a good shape and good concentration. And this, with the help of a catheter, we deposit it directly inside the uterus. So patients where there is some cervical factor which is making it difficult for the sperms to bypass and enter the uterus, or patients where the couple is having difficulty in having intercourse or timing their intercourse, what we're doing is that we're putting a good concentration of motile sperms close to the egg precisely around the time when the patient is ovulating. So this tends to improve your chance of conception to about 10 to 15%. And it is found to be effective in patients with unexplained infertility. Now, the whole question is that should we be doing it in a natural cycle, or should we be doing it in a cycle where we have given you some medicines to try and make the eggs grow? Well, the research which has been done in this regard has pointed out that in patients with unexplained infertility, IUI is more useful if it is combined with a cycle where the female has received some medicines in order to make the eggs grow. How does it help? Well, normally you usually have about one egg growing per cycle. With the help of the tablets which we give you in order to make the eggs grow, we're seeing to it that about 2 to 3 eggs grow at a time. This helps increase the chance that at least something would get fertilized. It increases the odds that one of the eggs would get fertilized. And it also helps in improving the hormonal milieu which is there. So by increasing the number of eggs and increasing the concentration of good quality sperms which are interacting with each other, we're improving your odds of conceiving. So that's the way IUI usually helps in patients with unexplained infertility, and it's a very commonly offered therapy. A lot of times we have this whole debate about whether we should be doing a single IUI or double IUI in a cycle. Well, there hasn't been much data to prove that double IUI is better, but it might have some role in those patients where the male partner has some motility issues, so or the sperm survival is low. So in these cases, double IUI might have a slight edge over a single IUI in one particular cycle. Now, how many IUIs can you really offer the patient? Well, research usually says that it's up to the best chance of conceiving with IUIs is in the first 3 cycles. If you see post the first 3 cycles of IUI, the success rate fairly plateaus. There's not much improvement if you just continue doing IUIs one after the other. The maximum chance of conception with an IUI is in the first 3 cycles. However, you might offer the patient, depending upon their age and their affordability, up to about 4 to 6 cycles of IUI. Now, what if the IUIs are also not really working out? Well, in that case, it means that your unexplained infertility is something which is not being managed by simple treatment. You need to go higher up in the treatment regime, and what comes next is an IVF or an ICSI. Now, what is an IVF or an ICSI? What happens in an IVF is that we give you some medicines daily, injections daily, in order to make all the eggs which are going in a particular cycle grow. And once they are ready and of the right size, we retrieve them through the vagina with the help of a needle. These eggs are then combined with the husband's sperm in the laboratory, and then the embryo is grown in the laboratory to up to 3 to 5 days. And once it reaches this stage, it is transferred into the uterus by means of a catheter, which is similar to the IUI procedure, which can be done either in the same cycle or after break of 1 or 2 months. Now, this particular procedure of IVF has the highest success rate amongst all the treatment options which are available for unexplained infertility. With IVF, you can expect a success rate of almost 50%. The success rate largely depends upon the age of the female partner and what is the duration of infertility. So you can almost expect success rate of almost 50%. And like I was discussing the possible causes for unexplained infertility, as you can see, IVF and ICSI for that matter takes care of most of these problems. If there was a problem with the ovulation of the egg happening, which was responsible for the unexplained infertility, IVF is overcoming that because we are not waiting for the egg to ovulate. We are directly aspirating the eggs from the ovary. If there was a problem with the functioning of the tubes, we are not dependent on it anymore because we're just taking out the egg, combining it with the sperm in the laboratory. There's no need of the tubes out here. We're just totally bypassing the tubes. And so that thing is totally overcome. If there was a problem with the quality of the eggs, that is being diagnosed with IVF. So it's not only therapeutic, it is also diagnostic. And the other thing is because you have more eggs which we are growing in an IVF cycle, we are being hopeful that at least some of these eggs would have a chance of combining and giving a good quality embryo with the sperm. If there is a problem with the fertilization where the sperm is not able to penetrate the outer layer of the egg, the process called ICSI, which is known as intracytoplasmic sperm injection, is overcoming that. Because here we are picking up one sperm, and injecting it directly inside the egg. So we're not even leaving the process of fertilization to the sperm to do by itself. So this is very helpful for patients where there's basically infertility happening because of failed fertilization. And if there is a problem with the implantation, which is responsible for the unexplained infertility, IVF overcomes that as well, because when we're doing a frozen embryo transfer, we can try and kind of personalize the embryo transfer in a way with various techniques which are available to us so as to overcome this particular problem. So IVF has great success, it has a great role to play in patients with unexplained infertility. Then why don't we offer it to everyone? Why don't we say that, okay, a patient has unexplained infertility, let's just jump onto IVF? Because it might not be a feasible option for everyone. IVF is expensive, but it is the most successful treatment option available for unexplained infertility. So the ones we usually start, if I were to look at it step by step, let's look at the wife's age, let's look at the duration of infertility, and let's see whether she has a good ovarian reserve. If all these parameters are good, then you can tell the patient that we usually discuss with the couple that, see, you have a good chance. Maybe you can try for a couple of more days and make some lifestyle changes to improve your chances of success. If there is a patient who gives some history suggestive of endometriosis, like painful history or painful periods, or if there is some history of any tubal surgery in the past, or they have some pelvic inflammatory disease, these patients, we can usually subject them to a laparoscopy to try and find out if the pelvic anatomy is normal, if there is something which we can try and correct to improve their chances of pregnancy. The third thing which might help these patients is IUIs, and up to 3 to 4 IUIs is what we usually look at to try and improve their chances of conception. And this is usually combined with an ovarian stimulation where we give the wife tablets in order to make the eggs grow. If all this is still not working, then IVF should be the next step. Now, for those patients where the wife is more than 35 years, or she has a borderline reserve, or for those patients where they have been married for a long duration of time and taken a lot of treatment, well, in that case, it makes no real sense to sit and wait, tell them, let's try for 2 more years, expected management करते हैं, उसके बाद फिर laparoscopy करेंगे, फिर ये करेंगे. No, we have to look at the patient as a whole and we have to address their concerns. So in these patients, the step would be that, okay, maybe if they haven't had an IUI before, maximum maybe 2 cycles of IUI, and after that, directly fast forward to IVF. Because as the female partner's age is increasing, the chance of success with IVF will also deteriorate. So this is how the embryo grows in the laboratory. Now, how do we improve the chance of success with IVF? Well, when we're doing an IVF, the main things which we're concerned is concerned with is try and improve the egg quality, try and improve the sperm quality, and in patients where we are anticipating failed fertilization, take them up directly for the process called as ICSI. So how do you improve the oocyte quality? We improve the oocyte quality by giving the patient antioxidants. So patients who have PCOS, in those patients, we usually advise the patient to try and lose some weight before they undergo the IVF procedure, because that also helps in improving their insulin sensitization and response to treatment in general. Sperm quality can be improved again with the help of antioxidants. We can try and find out if there's raised DFI and do various interventions in order to reduce that factor. And I've already spoken about how do you overcome failed fertilization with the help of ICSI. Besides this, there's a whole range of treatment options which are there in IVF, which we can probably discuss at another time to try and improve the chances of patients with unexplained infertility, like laser-assisted hatching. We can do a personalized embryo transfer. We can do check for DNA fragment index being raised, and do different sperm selection techniques in order to lower that parameter. So there's a whole range of treatment options which are available for unexplained infertility. The take-home message from today's FB Live should be that just because we don't know doesn't mean we can't treat it. The reason we don't know is because the routine tests which we do are not that advanced to pick up all the small things which can go wrong in the reproductive process. However, there are a lot of treatment options which are available which can bypass all the things, most of the things which are going wrong. And the chance of conception, even with this particular group of patients, is very good. So you should be optimistic about it. It's just about going to the right doctor and taking the right treatment. So that was about today's session on unexplained infertility. If you have any doubts, please feel free to post in the chat section. Okay, so if anyone has any doubts, they can share it on our website on the given number. You can contact us at our clinics, and we'll be happy to solve your queries. Thank you so much.